Okay. Welcome, everyone. I think we've hit a critical mass, so I'm going to get started. I'm just going to talk a little bit about why we're having today's grand rounds. So at Smilo, I know that we give patients the very best cancer treatment that's available. But we also know that giving excellent cancer care means treating the whole person and not just their malignancy. A few recent cases have brought to light that as oncologists, we really struggle with what to do when our patients have concurrent mental health problems. So we invited Dr. Sledge here today to discuss evaluating depression and suicide risk in patients with cancer. He's going to talk to us for about 20 minutes with slides, then a little more, and then he really wants to engage us in a discussion, so I'm hoping that everybody participates. Dr. Sledge is the George and Esther Gross Professor of Psychiatry. He did his undergraduate work at Washington and Lee University in Virginia, and then attended Baylor College of Medicine. He did his residency in psychiatry here at Yale, and then left where he was an active Air Force psychiatrist in Texas, in San Antonio, and returned to Yale in 1977, where we've kept him since. He's had many distinguished positions, including interim chair, acting chief, and most recently deputy chair for clinical affairs. He's attempting to retire with a phased retirement, but at the rate at which we keep pulling him in, I'm not sure we're ready to let him go. He's had grants from the NIMH and Health Services Research and wide and voluminous publications. At Yale New Haven Hospital, he developed the Behavioral Intervention Team, where mental health care is integrated into the care and embedded in the care of medicine patients. And this is a model that we hope to emulate in the near future at Smilo. Thank you.
Well, thank you very much. It's a great honor to be here today and have a chance to talk to you all about something that's really very important for all of us, which is suicide. Suicide is a very difficult issue to deal with, and we tend to shy away from it and pull back from it, both in general and also in specifically with patients. And of course, with patients, that's about the worst thing we can do. So I want to hopefully bring a little bit of familiarity to the business of suicide assessment today and make it a little bit easier for you all to engage patients who may be suicidal. So I want to run through a couple of, well, more than a couple, but a series of quick slides for thinking about suicide in general. And if I can find the pointer, which I have hidden from myself. I have it here somewhere. I thought, well.
Does anybody have a laser pointer?
No, let's see. I can. Here it is. Right where it's supposed to be. So what I'm going to talk about really is suicide in general, some risk factors, some theories about suicide and cancer. There's some interesting demographic issues and clinical issues in cancer that make cancer unique in terms of suicide, and then the business of assessing and treating people who are suicidal. So suicide in general. Well, suicide is growing as a cause of mortality in our country and in fact, worldwide. There about every 15 minutes or so, less than that now, someone kills themselves. And worldwide, there are over 1 million people who die from suicide a year. The United States, it's the 10th leading cause of a medical condition for, or 9th, I think, actually now, for mortality. One of the things that frequently happens, and this is true on campuses where you have college students, is once that someone kills themselves, it kind of makes it easier or more attractive for other people to kill themselves. And so suicide, in a way, acts a little bit like an infectious disease. So it has a contagious effect. Obviously, it's transmitted through imagination and not a pathogen. But the pathogen is the fact that somebody you know or know of has killed themselves, and it makes it a little bit easier for you to do so if you're kind of struggling with that. And so the way I think of it is that a community, a social community like a college, has a kind of thin web of a gossamer web of supports and restraints that in the social system keep people from doing horrific things if they feel like it or inclined to. But once somebody goes through that, it kind of breaks the web, and the web doesn't hold people in the same sort of way, and you have others that leap into it. Yale College, for instance, I was master of a residential college for 10 years, and during that time, there was no one killed themselves. I mean, it was for like 15, 20 years almost, where no Yale student killed themselves. And in the last year, there were like 3 deaths. And I told the administration when the first one happened that, look out, we're going to have to do things a little differently here, because there'll be more. And this is typical of many social systems. So suicide is not very well understood. We know a lot about what accompanies it, but it's not specific. It's specific, but it's sensitive, but it's not specific. It has no real predictive value. We know a lot about the risk factors, and I'll talk more about those, and we know a lot about the incidence and the associated comorbidities, but they're not sensitive enough, specific enough for us to make predictions. So we're not able to predict suicide, and we should just get that out of our minds. It's not possible to do. 3 common factors that are very often associated are a kind of feeling of unbearable pain, that you've gotten into a situation you just cannot stand it, and you began to think, I would be better off dead than have to live this life that's before me. And a hopelessness that's frequently associated with something like depression or a mental illness. And mental illness and substance abuse are very commonly associated with suicide. But there are a lot of people with this configuration who don't kill themselves and are not even thinking about it. So to be a little bit more specific, the affective disorder has a 20 times more association with suicide, substance abuse, panic disorder, psychosis, borderline personality. There have been developed specific treatments for psychotherapy of borderline personality that focus on suicide. The borderline personality has a very high incidence of suicide attempts. History of family who's killed themselves, a prior attempt, childhood abuse. These are all risk factors that combined, if you have them all stacked up together in one person, then you do have someone who's probably more likely, but you don't necessarily know. So there's been a lot of effort. To me, this effort is, I'm going to tell it to you. I don't want you to really think much about it, because I'm just trying to give you a sense of how people have thought about this in the past. This effort has no value in your prediction of taking care of patients, but it is a kind of way of conceptualizing and thinking about suicide. So impulsive suicide, where the person doesn't think much about it and just does it. Fatalistic suicide, where you do it because you're in a situation where you feel like you don't have any choice. And communicative suicide, when you're trying to punish someone else by your own death. And so these are all elements that frequently accompany some kind of suicidal act, but they're not helpful to thinking about it. We do know that people have different levels of lethality when they go to try to kill themselves. We know this because sometimes they don't succeed and they tell us about it afterwards. And some, it's intentional, very clear effort planned to take their own life. Then there are these sub-intentional things where someone goes into a risky circumstance, like climb the face of the The problem with is, and I'll get to it, is it's a risk management tool more than it's a clinical tool. And if you administer it like a risk management tool, it becomes more like an experience of an accounting. And there's nothing more off-putting than that to someone who's suicidal and who's really wondering, are you going to be somebody who's going to help them? Are you going to be interested in them? And if you go to talk to them and say, you're not suicidal, are you? Well, that's kind of like saying, don't tell me about it if you are. And they don't like that. Also, they don't like the questions. The questions are not coming out of a conversation. We'll come back to that, about the personal aspect of it. So, treatment. Because 90% of the people who kill themselves have a co-occurring mental illness, the first form of treatment is to treat the mental illness and to make sure that they're getting adequate treatment for that. Depression is by far the most prevalent, but also bipolar is also highly associated with suicide. But these other issues are too. Substance abuse disorders are also related to suicide. Many people who are addicted to opiates end up killing themselves somewhat accidentally, we think. Probably the most important thing is to learn how to talk to people who are suicidal. And I mean by that, not as an accountant asking accounting kinds of questions, but as a human being. And you can do both. You can do them together. But if you focus on the accounting part of it, you're going to lose the human being part of it. And so you want to find out, how much are people thinking about suicide? What are the circumstances? What brings it on? What is the ideation? Because the idea is 90% of the people who die thinking about suicide. In other words, suicide is an essential, suicidal ideas are an essential predisposition. And you want to know that, you want to understand that as best you can. And you want to, and for people to tell you honestly, you have to have something of a relationship. And that relationship has to have an element that they believe that you're there working for them and trying to help them in some kind of way. So you don't go forward and say, you're not suicidal, are you? I didn't think so. Okay, good. You don't do that. You say something like, tell me about the suicidal ideas you might be having. And that sounds like it's not a question. It is a question because you say might. And you're basically asking, are you having suicidal ideas? It's probably the gentlest way to proceed with the stranger. If you think you know that they are having suicidal ideas, you can say, tell me about your suicidal ideas. And, of course, that puts them in a position to deciding whether to lie to you or not. Because people who really want to kill themselves, they don't talk to other people about their suicidal ideas. And so it's interesting to me how reluctant many people are to lie to a doctor or a psychiatrist. They just don't do it for some reason. I don't really understand why, but they don't. If you think someone is suicidal, it's your duty in terms of if you have a treatment relationship with them to make sure they're protected and make sure that they're in a safe setting. The evaluation of the family and the living circumstances is essential to do when you're dealing with someone who's suicidal. So, questions, comments, thoughts? I know you've had some circumstances here lately that have been a challenge. I'm going to sit down if you don't mind.
Sit.
Yeah,
Absolutely.
right.
Is this on? You can, really? It's on? Now it's on. Good. Hello? Yeah, okay. Any questions? Yep.
Yeah.
That first month is the real high risk time
Yeah.
for people. And my experience of doing oncology social work is that helping people understand that the crisis of diagnosis is kind of a time limited, expectable emotional crisis that they're experiencing sometimes normalizes a lot of distress, and to represent at the time of diagnosis the new normal that needs to be found, that can be found,
Right.
can sometimes really be very reassuring. But I was wondering if those people, if those studies pointed out any other risk factors that those people carried other than just the within the first month of treatment. Did they have family disruption? Did they have a suicide in the family? Did they have a mental health history? What other factors?
Well, there are a host of risk factors, and and again, I caution you about how to use them because they're not predictive. So mental illness and substance abuse is clearly a big one. Any kind of trauma or painful experience is also a big one. Being a man is a big one. The incidence goes up in late suicide and early elderly, kind of as a peak in terms of the demographics. If you have a family member who's killed themselves, particularly somebody you're close to, that's a big one, particularly if it's a parent. If your parent died by their own hand, you're thinking about it almost all the time. And there are these enormously compelling fantasies of going to join them. And so that's a big one.
Thank you for this. So I have a question. In real life, if I have a patient who, I'm suspecting they may be suicidal, they opened their heart to me and they're telling me that.
Yeah.
So I feel like, I'm always concerned of betraying their trust by bringing the psychiatrist or or making that emergency, or you can't leave until you have a psychiatrist to see you. What do you do in this case? He trusts you with this information and you want to help them, but now you're making them I feel like I'm making them prisoners of my fear.
Right. Well, that's a challenging circumstance to be in, and but think of the consequences if you don't act. Probably, likely, they won't kill themselves, but they might, and they're more likely to than someone in the general population. And so, the first thing I would say is urge them to get help and help them get help. And so you become a kind of partner, not a police person who's turning them in, but a partner. You're a partner in making sure that they get connected to appropriate services. But if someone's telling you that they wish to die and they're contemplating dying, I think you really have to make sure they get evaluated by a professional, mental health professional, and with the idea of getting treated and treated effectively. Yep.
You, on your slides, there was one time where I saw the phrase suicidal ideation.
Yeah.
Can you define what it means and what we should consider? Do we consider any not so much on the slides, but how should we respond? When you think somebody on the offhand says, "Oh, I'm going to kill myself. This is terrible."
Right.
As opposed to someone saying it repetitively and over a number of days, or taking certain actions that might be. Is there any psychiatric depth to the term?
Well, so suicidal ideation is a very broad and general kind of idea, and so you want to get to as fast as you can how prevalent it is. Do they have do they think about it all the time? Is it just fleeting when they go to bed at night, or is it constantly nagging them? do they have a plan? Have they contemplated a plan? And have they done anything about this plan? So those are clear steps of intentionality that are moving along in a dangerous kind of way. And you want to definitely pursue that in as gentle and tactful a way as possible, and in a way that allows them to really talk to you about it. Sometimes just talking about it takes away the urge, and it becomes there's almost a kind of change in the sense of reality for people who become suicidal. They begin to feel like they're not really going to die, but they've just got to do this. And sometimes sitting down and talking to someone who's they trust and sensible, it'll decant this kind of idea. The likelihood of impulsivity is a very big risk factor, I would say, because on the suicide, so I've done all the suicide evaluations in our hospital for the last 20 years, and it's probably 200 cases or so. And the association of impulsivity is very high among these patients. And so if they have a tendency towards impulsivity, you really want to try to create some kind of barrier. Make sure there's somebody who's with them and knows about them and can talk to them.
Thank you for a very thought-provoking discussion. If it wasn't clear to me that suicide is increasing in the cancer population specifically, and if so, do you think that the aging population, which is true also of the cancer population, has anything to do with it, or the fact that medicine has become fragmented, the increasing fragmentation of medical care because of all the subspecialties and so on?
Well, I think that it is pretty clear that cancer has a higher incidence of suicide than the general population, of roughly twice as high, and I think it's pretty clear from the studies that I reviewed in anticipation here that a lot of it has to do with learning that you have cancer, as opposed to actually enduring it, and the fear of that. And so, to the extent that that comes at a point of relatively low morbidity in terms of being able to anticipate, you diminish the fearfulness and the demoralization of it. So I think what we all have to do, all of us, whether we're psychiatrists or nurses or oncologists or social workers, is feel comfortable in talking to people about it, and treat it as not something that we're going to shy away from, but something we're going to. How's this? How are you thinking? How are you feeling today? In a tactful way. You know, so how's your suicidality? You know, that's probably a little too forward. But how are you feeling today? And they say, well, I don't know. And you might say, you're having those suicidal thoughts again, aren't you? And, well, yeah, kind of. Well, tell me about them. And just have a conversation. And the conversation, but a directed conversation, a informed conversation, which is how prevalent, how likely do you feel you're going to act on it? Have you made plans, etc. That kind of thing. And I'll give you an example of a case. This is a case I'm involved in as an expert witness in another part of the U.S. And so this was a guy who was had some kind of on again, off again marital problems, drinking problem, kind of disabled prematurely with different kinds of, couldn't work as much, and it was kind of a sad case. And he decided to kill himself with an overdose. He took an overdose and woke up the next day and he wasn't dead. But his wife knew about it, and they had conversations and so forth. And she didn't take it that seriously, and he didn't either. But then he got feeling bad again. He got out a gun, and he thought he was going to shoot himself. He really was going to shoot himself. She found him before that. Maybe arranged it so she would. It's hard to say. And so got him to a hospital, and he went into the hospital, and clear suicidality. He was also an opiate user, and he began to withdraw, and he had pains that were the pains of withdrawal. They were worried it was maybe a heart attack, and they put him on a unit in a tower in the medical center. And decided, he didn't need telemetry. He wasn't having a heart attack. He was having withdrawal from opiates. Put him in a room where the windows were open. And he killed himself, leaping. Because in the middle of this kind of complication of the withdrawal, where was his family, he lost his bearings in a sense. So, it's important for us not to have things like that happen. And so we have to always treat people who say that they're thinking about killing themselves seriously, even though it seems like maybe a way of manipulating people, or maybe it's a way of trying to get attention and so forth. And we have to act in a way to make sure that they're safe from these kinds of impulsive acts. We've had several episodes in our emergency room in the last 5 years or so where we had a death. We had a suicidal death in our emergency room about 8 years ago. So.
My question, which I formulated before your anecdote, actually I think ties into it a little bit, but I was wondering about the very many things that we prescribe as oncologists which are psychoactive. So we use benzodiazepines for sleep and nausea. We use steroids all the time. We use a lot of opioids.
Right.
And if a patient, sometimes we prescribe an SSRI ourselves because the patient's not seeing a psychiatrist.
Right.
So if a patient is becoming more depressed, what sort of precautions should we take with our prescribing, I guess?
Well, you want to treat the depression in the best way, and so it depends on their history of what they've responded to in terms of what you want to use in terms of the psychopharmacology. But I think it's really important to ask everybody who's clearly depressed, are they thinking about hurting themselves or killing themselves? And to do that in a kind of matter-of-fact, calm way. And say, we realize that sometimes people feel really down and out because you've got depression, and you may feel like hurting yourself, and there's nothing unusual or bizarre about that. I just want to know how you're on that score. And most people will tell you. Even though they may be planning it, they'll tell you. It's odd how honest they'll be if you ask. But someone who's decided, I'm going to kill myself, I have a plan, they're not going to tell you. And you can usually figure that person out by the history. They've had a history of suicidal ideas and efforts, and then all of a sudden it goes away. That's when you have to worry.
So the question is somewhat related to this. So you said several times we can't predict suicide.
Right.
But once we suspect or we identify someone who is at risk,
right,
we have certain interventions that we can provide, a lot of support, talk,
right,
and safe, etc. environment.
Right.
But in other psychiatric disorders, is there any effective pharmacological intervention that can minimize or mitigate suicidal ideation?
Nothing that's on the market right now Ketamine is something we're exploring. Ketamine has a remarkable effect of reducing depression, like in hours. And with it, if you're suicidal, the suicidal ideas too. So we're developing a way to use it. So it doesn't work after about the third or fourth time you've tried it. So typically, so we're using it in a kind of we call it jump starting. Most of the treatments for depression take a while. The pharmacotherapy takes 2 to 3 weeks before it's going to kick in. The ECT takes a couple of weeks of being in the hospital. The RTMS takes even longer. And so this is a way of getting it right away, and we're trying to figure out, are they compatible? Are the treatments that we use standardized? Are they compatible with a jump starting of ketamine? Because ketamine's doing this in a very different way, and we think we understand it, but it's not completely clear. But ketamine is definitely on the horizon as a savior in this process.
I think there's some use of ketamine in the palliative care population as well, right?
Hadn't heard that, but I'm
Yeah.
severe depression
Severe.
and pain. Yeah, right. Does it work repeatedly, or is it a? Yeah.
So I think a lot about how we communicate with our patients,
Yeah.
and I think we walk a tightrope really between giving patients an honest understanding of their prognosis and killing all hope.
Right.
And
Yeah.
we do a lot of work about really helping patients know and expect what's coming, but I think we all operate with some fear that we're going to tip them over the edge.
Right.
Any advice?
Well, I think the best protection is knowing your patient and having a bond with them where it's clear to the patient that you're on their side, and you have a sense of their vulnerabilities and their strengths, and you play to their strengths and respect their vulnerabilities. So you talk to everybody differently. I mean, there's some people where you've got to tell them everything right up front. They're not going to trust you or believe you ever again if you don't do that, and just like hit me with the bad news, and they mean it, and that's the way they are. Then there are others that don't want to know everything, but they kind of need to, and you have to find a way to kind of get that across in a sense, in a tactful way. So it takes time. That's part of the problem. It takes time to get to know folks like what I'm suggesting.
I had a question, which is, I've always wondered if there's data that actually shows that management of depression or distress or anxiety actually improves outcomes for cancer patients. I mean, we all are aware of our psychosocial resources for our patients and the need for that. But is there anything that actually in the literature shows that if you improve that, you can improve how our patients do?
Well, I don't know. In a way, it seems like an obvious answer, but it may not be. I think the best data I'm aware of is the role of palliative care in reducing worry and fear and increasing longevity. Palliative care is enormously honest and straightforward, and yet tactful at the same time. So I would quote that literature to answer your question.
So this weekend in the snow, I've just finished When Breath Becomes Air, which is out on it's a new book that was written by a neurosurgeon that was diagnosed with stage 4 cancer. Mm-hmm. And he was in his final year of residency, and he really spoke about the importance of the medical people helping him reframe and redefine meaning in the face of a terminal illness. And it should be required reading. I'm going to suggest it to Dr. Schwartz in front of me that we have a book club for our service. But it was so well written, and it was written from the eyes of a physician.
Yeah.
And I think it had so many really kernels of wealth for us to all put into practice. So, and I think if we approach it like that, then you prevent feelings of suicide because you're getting to know your patient. You find out what makes their life meaningful and how to help them complete their life in a meaningful way.
I completely agree with that. I think that's that if you can have an honest conversation with somebody who's dying about what they're worried about most, what they're fearing most, that's an enormous gift to them. And like I say, I've had more experience with it than I'd like to have, and it makes a lot of difference, clearly.
The common theme I keep hearing is your one bullet talk.
Yeah,
That's
right.
the most important thing is that we take the time to do that. We have time for one more question. I think looks like we're there. Thank you so much.
Thank you all. Thank you.
Really, thank you so much. Breath becomes air. Yeah. Thank you so much. It was a new talk.